So welcome everybody. This is Cambridge SEMSOC's talk on neurotrauma and motorsport medicine by Professor Hutchinson. So thank you. We can begin now.
Okay, great. Thanks very much, Clint. Thanks for the invitation. So I'm going to talk about the topics of traumatic brain injury, which I'll start with a more general talk about TBI in general, the causes, how we classify it, and mechanisms, treatment. And then I'll focus on the management of motorsport, TBI, but also I thought probably more interest to you, given the name of your society, motorsport medicine in general, and how we run the medical team for the British Grand Prix. So starting off with TBI management, traumatic brain injury has a number of different causes. Road traffic accidents, assaults, falls, and relevance to you, of course, is sporting injuries. And whatever the cause, this is a journey for a patient from the scene of an incident through the emergency department. Some patients require surgery with some more severe injuries, intensive care, rehabilitation, and reintegration into the community. Overall, it's the commonest cause of death under the age of 40 years in high-income countries and a major cause of morbidity for survivors. So as I said, these are the common causes. Sporting injuries are increasingly relevant, particularly in terms of mild traumatic brain injury, concussion, the diagnosis and return to play, but I'll come back to that. If you look at TBI more general in our part of the country, so the eastern region, it's a very common condition. There are in this region about 5.4 million people that we cover, and we're seeing 100,000 head injury patients per annum with about 10,000 admissions. So it is a very, very common condition. How do you classify head injury? Well, the mechanism can be closed or open, and a closed injury, high velocity RTA and low velocity falls, assaults, so most sporting injuries fall into that latter category of the low velocity, and open injury, gunshot wounds, other penetrating injury where there is breach of the scalp and the skull. You'll be familiar with this. The second way we can classify is by severity, and they can be either mild, moderate, or severe. Mild is a GCS of 13 to 15, moderate a GCS of 9 to 12, and severe is a GCS 8 or less. And there is a word for that, and that word is coma. The morphology, so this is actually the anatomy of the injury. In essence, when you injure the head due to sport or what other reason, then you can injure the scalp. So sporting injuries, that's commonly what's injured in terms of contact sport, but more severe injuries can result in skull fractures. And skull fractures can be divided into the vault. So the top part of the skull, linear, so a simple fracture, stellate, star-shaped, or depressed. And base of skull fractures are important because they can be associated with a CSF leak. Within the brain itself, you can have what's called a focal injury. So that's generally a contusion, a bruising of the brain, or a blood clot, a hematoma, extradural, subdural, or intracerebral, or you can have a diffuse injury. Now, the diffuse injuries are interesting because they range from the mildest sort of injury where there is a transient loss of brain function, which is called concussion at one end, diffuse injury, and then at the other is a severe diffuse injury resulting in coma, the pathophysiological substrate of which is termed a diffuse axonal injury. Given there are 100,000 patients presenting to hospitals in our region with head injury, we cannot possibly CT scan all of them. So these are the NICE guidelines. And this is really relevant to sport in terms of if you see a player who has sustained a head injury and has these risk factors, they should have transfer to hospital and a CT scan of the head immediately requested. So if their GCS is less than 13 at any point since the injury, 13 or 14 at 2 hours after the injury, a suspected open or depressed skull fracture, signs of a basal skull fracture, a seizure, focal deficit, or more than one episode of vomiting, amnesia for greater than 30 minutes, then they should have a CT scan. The problem that patients with moderate and severe injury face is that the trauma to the head results in brain swelling. That occurs in a tight box, the skull, which results in increase in intracranial pressure, a reduction in cerebral blood flow, cerebral hypoxia, energy failure, and this increasing cycle of brain swelling resulting in poor outcome for the patient. So the treatment of major head injuries is by the ATLS protocol. Are you familiar with the ATLS protocols, or you'll have heard of ATLS? I think as students, you can be observers on ATLS courses. Following graduation, then it's something that I strongly recommend. So ATLS protocol is what we call the primary survey, so addressing the airway, breathing, circulation, disability, and exposure, in parallel with resuscitation, a full exam of the patient, a secondary survey, and transfer to definitive care. The golden rule of the treatment of major head injury is to maintain good oxygenation of the blood in the brain and maintain a good blood pressure to avoid hypotension. And you do that by securing the airway. And if you're in coma, that involves intubation and ventilation in concert with fluid resuscitation. And we know that if you're hypoxic and hypotensive, then the prognosis is very poor. Neither factor, the prognosis is much better. The treatment of major head injury begins at the scene through emergency department, CT scanning, neurosurgery, and intensive care for what we call ICP monitoring. Some patients may need transfer to the operating theatre. These are some of the pathologies that you see in head and traumatic brain injury. So this is seen in sports injuries. I've seen this in a number of sports injuries where there is a blow to a head. We had somebody who was kneed in the head while playing cricket. They were unconscious for a short period of time. They then recovered consciousness, and then several hours later, they became increasingly unconscious. And that is this what we call lucid interval, with this extradural hematoma, bleeding from the middle meningeal artery, peeling the jaw away from the bone. Small extradurals can be treated by observation, but larger ones need surgery, a craniotomy to remove the extradural hematoma. These are relatively rare. More common is this, acute subdural hematomas. These are often seen in elderly patients with falls. They are generally venous. They are generally associated with damage to the underlying brain. And the extradural has this biconvex appearance, whereas the acute subdural has this crescentic based appearance shown here. Large acute subdurals require surgery to evacuate them. This is bleeding within the brain itself. So if that is a pure blood clot, that's called a hematoma. If it's a combination of blood and bruised brain, it is called a contusion, and it usually affects the frontal and temporal lobes. It may be what we call coup or contra coup. So you get a blow at the back of the head, you get bruising at the front of the brain. That is called a contra coup hematoma / contusion. And then this is diffuse brain injury. So there is no blood clot. There's nothing to evacuate surgically, but the brain is diffusely swollen, diffuse axonal injury, and the treatment of this is medical management, at least initially. What about surgery for these patients? So surgery can be performed for acute lesions, usually blood clots, or the management of raised intracranial pressure. And the acute surgical lesion can be taking out an extradural hematoma, a subdural hematoma, or an intracerebral hematoma, or elevating a depressed skull fracture. But surgery can also be used in diffuse injury. We can place drains into the ventricles to remove CSF. We can evacuate brain, a contusionectomy or a lobectomy, or we can operate to reduce brain pressure by undertaking this operation called a decompressive craniectomy. This is what cranial surgery looks like for brain trauma. This is what we call a classic trauma flap, so a large question mark flap. So this would be for an acute subdural hematoma. The scalp has been reflected, the bone is exposed. This patient has a fracture that you can see there. We remove the bone, open the dura, and that is a very angry, swollen brain. You can see it's bruised, contusion, these markings on the surface, and you can see how the brain is under pressure. It is herniated through this craniotomy. Pressure is what we measure in these patients. How do we do that? Well, we can put a probe into the brain, an intraparenchymal sensor, to measure the intracranial pressure, and a normal pressure is 10 millimeters of mercury. Above 20, it is abnormal, and above 40, it is severely abnormal. We can monitor the pressure continuously on intensive care. So this is a patient's intracranial pressure over several hours. This is a patient's blood pressure over several hours. And what's really important is the difference between the blood pressure and the intracranial pressure, and that is called the cerebral perfusion pressure, shown here. And we need to keep the cerebral perfusion pressure ideally above 60 millimeters of mercury. So this pressure by putting this probe in the brain is really, really important. It's what we do to all the patients. But we can also use other technology to measure some of these other parameters: blood flow, brain oxygen, and microdialysis brain energy failure. So we can put probes into the brain to measure how much oxygen is there in the brain. This is a normal brain tissue oxygen. We can put in other probes. This is a microdialysis catheter to measure brain chemistry. So we can measure how much glucose there is in the brain and how it is metabolized to pyruvate, lactate in adverse circumstances. So you're familiar, I'm sure, being much nearer biochemical studies than myself, but you will recall that glucose is metabolized by glycolysis to pyruvate in biochemistry, converted to acetate, which enters the TCA cycle. Glycolysis produces about 2 molecules of ATP per 1 of glucose. In the TCA cycle is where ATP is produced in large quantity. If there is hypoxia or mitochondrial dysfunction, pyruvate is preferentially metabolized to lactate, and this lactate pyruvate ratio is a marker of hypoxia or mitochondrial dysfunction. So as well as what we do now is keep the pressure less than 25, the brain pressure, the ICP, the cerebral perfusion pressure greater than 60, the brain oxygen greater than 15, and this ratio of lactate pyruvate, this marker of hypoxia or mitochondrial dysfunction, less than 25. And we do that through these therapies of anesthetic sedation, draining CSF, increasing the blood pressure, hypothermia, and other more advanced interventions. So just to show you going back, this is the cranial access device. This goes into all patients with head injury on intensive care routinely. It transmits a pressure probe, an oxygen probe, and a chemistry probe. Now, I just want to focus a little bit on some of the clinical trials in head injury. There's been lots of attempts to try drugs to try and improve the outcome from head injury, and they've worked in animal studies, but they've not really worked in patients. And what we've tended to do is focus on surgical intervention. So this patient has an acute subdural hematoma. We need to operate. So we're going to do a craniotomy. We're going to remove the bone flap. We're going to take out the hematoma. If the brain is swollen, we can leave the bone out. That is called an acute subdural hematoma, primary decompressive craniectomy. Another indication for surgery potentially is this, where the brain is diffusely swollen. The pressure is really high. We've got to bring the pressure down. And one way to do that is to open the skull, and that is called a decompressive craniectomy. So here, this is a decompressive craniectomy for diffuse brain injury, where we've opened the scalp, we've removed a large piece of the frontal bone, and here is the dura exposed, then we open the dura, and that is called a decompressive craniectomy. Now, in order to try and gain the evidence as to whether this is the right thing to do, we've performed this trial, a trial of decompressive craniectomy for traumatic intracranial hypertension. The hypothesis being that if you open the skull, you could improve the outcome by reducing pressure in patients with head injury. So we randomized patients as part of this study into medical treatment, including these barbiturates in one arm versus the surgical procedure in another. And when we looked at the outcome according to this Glasgow outcome scale, we looked at the patients who are doing relatively well. So these upper severe disabilities independent at home or better compared to lower severe disability dependent on others for care or worse. And we randomized over 400 patients. And what we showed is that if you took surgery to try and control pressure, you had a marked reduction in mortality with surgery, but higher rates of these poor outcome categories, lower severe disability and vegetative state. But when you get through to 12 months, you begin to see some changes, and approaching a half of the surgical patients were in the more favorable outcome category compared to about a third of the medical patients, and that became significant. And if you treat 100 patients with this operation to control brain pressure compared to medical treatment, you save 22 more patients. And these are their categories of outcome. About 60% of them are what we call favorable upper severe disability or better, but there are a number that are in what we call vegetative state or lower severe disability. So this operation no doubt saves life, and many of the patients are doing well, but what we need to try and work out is how we can improve the outcome for those patients who are left in these vegetative and lower severe categories. So in terms of the end of the first part of the talk, that's an overview of the management of traumatic brain injury. I'd like to acknowledge my colleagues, both locally and internationally, and the NIHR for funding our research. I don't know, do you want to take some questions now, or shall we crack on and I'll talk about the motorsport and maybe take questions at the end? Maybe that would be the best way of doing it. What do you think?
Yeah, I think that would be better.
Yeah, then we know how much time we've got. So I'm aware you're the Sports Medicine Society. So I thought, in addition to talking about traumatic brain injury more general, it might be of interest to you to discuss some of the issues in terms of the management of sports injury as a result of motorsport. And in terms of my sort of personal experience, that has been through various levels of motorsport, what we call grassroots motorsport, so club motorsport, but then building up to the high levels of motorsport and the medical team that provides cover for both the drivers, officials and spectators at the annual Formula One British Grand Prix that is held in Silverstone every June/July, and there is one, of course, coming up. The British Grand Prix is just at the beginning of July. So I run the medical team for the Grand Prix. If you look back at the history of motorsport medicine, it dates back several decades, and some terrible accidents that used to occur. This was Sterling Moss at Goodwood. He survived this, but he was never quite the same again. And Formula One in the 60s and 70s was terrible. There was a real risk of mortality for Formula One drivers, and this was. Do you know who this is? This is Sir Jackie Stewart, who said to be a racing driver between 1963 and 1973 was to accept the probability of death, not the possibility, the probability, because the statistics suggest that if you're a Formula One driver 5 years or more, you are likely to use your life on the track than to survive or retire. So this was a really dangerous sport. And I mean, you're all relatively young, but this was one of the higher profile deaths at the higher end of the motorsport, and this was the death of Ayrton Senna in the San Marino Grand Prix in the 1990s. And that was a very defining moment, because a number of people realized that we could not go on like this anymore. Most notably, Professor Sid Watkins, who worked with Bernie Eccleston to really get motorsport safety up the agenda. And in fact, although it's perceived as quite dangerous, there are some other very dangerous sports out there, including swimming, horse riding, air sports, and fishing. And I'm sure you'll be aware of some of the injuries that can be due to these other sports. As well as looking at safety of tracks, some of the advances in motorsport medicine relate to technology and equipment. So clearly the helmet is routine, but this device, the HANS device, which sits behind the head and supports the neck, has been very influential in reducing severe neck injury. And then I don't know how closely you follow the sport, but a few years ago now, we introduced this technology. This is the Halo, and that is designed, this is titanium, that is designed to prevent some of the injuries through direct contact. Injuries that used to kill people were a loose wheel or one car on top of another. And you'll recall the accident at Monza last year where Verstappen's car ended up on Hamilton's. And there is no doubt that the Halo has been a major contributor to safety in motorsport. So this is the HANS device. Without the hands, you can see this pronounced neck flexion. With the hands, the HANS device is restraining and protecting the neck. So the Grand Prix at Silverstone has been running for since the 1950s. As I said, it's an annual event. It has changed over the years. This is Silverstone. It's in Silverstone's a village in Northamptonshire. That is a satellite image of Silverstone Circuit, and it started life as a Second World War base for bombers. Wellington bombers were kept there, and in fact you can see, if you look at some of the patterns of the roads, this was actually one of the locations of runways, and in effect the Grand Prix circuit grew out of the airfield, and the perimeter road was the start of the configuration of the Silverstone circuit. So there are a number of circuits within Silverstone. This is what we call the Grand Prix circuit, which is the main circuit for the Grand Prix. But you can see within that there are some smaller other circuits with different configurations. In terms of high-profile motorsport accidents at Silverstone itself, this was Michael Schumacher's accident, late 90s, where he went into the tyre barrier at Stowe. He sustained a fracture of his tibia. This was the two things have really changed since then. We've tended to move away from gravel. So gravel, the cars tend to skate across the gravel. So there is some evidence now that actually hard tarmac in the runoff is better than gravel. And also, can you see how the front of the car has actually penetrated through this tyre wall? So now you'll notice that there's this Tech Pro that actually covers the tyres with a continuous conveyor belt type covering. I don't know if you saw the Monaco Grand Prix, which was the last race out, this barrier was damaged, and it's understood now that is not acceptable. The race actually got red flagged, it got stopped because the barrier must be properly repaired. These are some other incidents. Now, in terms of the planning for the Grand Prix, that starts several months before, and the governing body for Formula One is called the FIA, the Fédération Internationale Automobile, based in Paris and Geneva, and they produce this questionnaire in terms of the medical requirements to operate a Formula One race safely, and that includes designated hospitals, of which Addenbrooke is one for Silverstone, major incident planning and recruitment and allocation. So Silverstone, we tend to use major trauma centres for major injuries for the drivers, either fly them to Oxford, to Coventry or to Cambridge. We also have a responsibility for the crowd, and we tend to use Northampton General Hospital for crowd issues. There are about 140,000, 150,000 people there on the Sunday of the Grand Prix. That is a lot of people. There is potential for serious injury to drivers, spectators, officials, etc. And we put an awful lot of effort into major incident planning. And that includes planning in relation to terrorist events such as the Manchester Arena bombing. These are real threats, they're ongoing. So we plan and we undertake exercises to look at all sorts of eventualities. What about the medical team itself? So this was one of the very early races at Silverstone, and this is the doctor. You can see he's wearing his nice jacket, trousers. He's not in fireproof overalls as we wear now, rushing to the scene of an incident. And we've moved from that to the medical team at Silverstone, which is a team of over 100 people now to cover everything on the track, the officials, the pits, the paddock, the crowd, the hospitality, the whole event, a team of doctors, nurses, paramedics, ambulance staff who come together for those 4 days to provide safe medical cover and running of the event. Our mission is to provide seamless high quality care from an incident site through to a medical facility and delivery to designated hospital according to HLS principles. What the challenge we face is that when we're treating a driver on the track, that we're immediately internationally vulnerable in terms of the media coverage, and the television is intrusive and global. And you've seen the images of what happened in terms of some of these incidents. It is immediately out there, and that's something we have to be aware of. The circuit itself is run out of what's called race control. That's where I sit as the chief medical officer, and the whole of the circuit track, grandstands, immediate environment is covered by a closed circuit TV camera. So these cameras can target any part of the track. We can see the whole circuit. Each camera can be rotated, zoomed in and out, and you can follow the sequence of a car by following the sequence of the cameras, and we can immediately see what's happened to an incident. At the top here, we have the timing screen, so we know the timing screen for each car. This camera is directed if there is an incident. You can take one of these smaller images and portray it on the bigger screen. This is the public television, and up here we have satellite navigation. Each car has a device so we can locate it on the track, so we know exactly where each car is in time. We have designated response times, so we have to respond to a fire within 15 seconds by the marshals, 30 seconds by a mobile fire tender, and we have to get a doctor to a driver within 90 seconds, wherever they are on the circuit. If there is an accident or an incident, it is by regulation that we have to find somebody to be there within 90 seconds. And you can imagine that that is often quite a challenge depending on where it occurs. How do we achieve that? The medical cover is provided by both car and ground posts. So we have 5 medical cars with doctors, anaesthetists located at strategic points around the circuit. We have the FIA medical car, which is the Mercedes or Aston Martin that my colleague Ian Roberts sits in, that follows the first lap of the race. So that is located here. Then we have a further medical car. This is called Farm. We have one at Brooklands. We have one here at Beckett's. We have one here at Stowe. So these are the medical cars. These are fast response cars, got some really good medical kits in them, intubation, fluids, defibrillator, everything you'd need to respond to an emergency. Each of these cars can get to an incident generally within 90 seconds. But often the race is not stopped when there's an incident. So at each of these vulnerable corners, we have a doctor on foot. You can see there's the doctor dressed in red who's at that corner. And that's really important, particularly for me in race control, because when there is an incident, what we need to know is whether the driver is injured and the nature of that injuries. And that is fundamental in terms of decision making. Is that a yellow flag? Is that a virtual safety car, a full safety car, or does the race need to be stopped? So it's really important in terms of communication from these ground post doctors to get an immediate idea of the condition of a driver. What we tend to do is we try, if we can, to keep the race running through a virtual safety car or a safety car rather than a red flag. So historically, we've used Mercedes-Benz for the medical car. Over the last year or so, the medical car has either been a Mercedes or an Aston Martin. This is the Aston Martin safety car. That is the start of the race. So I don't know if those of you who watch it, so this is the FIA medical car, which follows the first lap. Most incidents, the higher risk of incident is during the first lap. So this medical car follows the whole pack. And if there is an incident, it will stop, assess whether a driver needs to be picked up, taken back, whether we need a safety car or even to stop the race. But this car follows the first lap. It is amazing the speed difference between an F1 car and this medical car. And within a lap on a long circuit, it is incredible how close the lead car can get towards that medical car. So that medical car exits and comes down the pit lane. So as I said, we have 5 medical cars. We also have a team specializing in extrication. That's how you get drivers out of cars, particularly when they've got spinal injuries, the trackside doctors I've talked about, and then we have 3 ambulances trackside. The medical center has deputy chief medical officer and consultants in all trauma specialties and a GP. This is the extrication team. So we have 2 of these teams in extrication van. This is an exercise where the team are assessed by the FIA in terms of how quickly and how safely they can get a driver out of the vehicle. 1 doctor, 4 other team members. In F1 and F2, the seat is now detachable, so the driver actually comes out with the seat. That is an option in terms of extrication. This is us practicing extrication at Red Bull. So again, this is absolutely essential, and we practice this all the time. This is Ian Roberts, who you may know. He's the rescue doctor, the chief rescue doctor for the FIA. He goes to all Formula 1 races and sits in the car at the back of the pack. In the center of the circuit, we have the medical center. So this is in effect, it's a small hospital within the confines of the circuit. It has a 4-bay resuscitation area, a burns unit. We have access to X-ray, ultrasound, ward, 2 4-bedded wards, a major injury room, and a helipad. We manage patients, as I said in the first part of the talk, according to the HLS protocol. And we have consultants. It's a pretty good place to be ill on a Sunday afternoon because you've got consultants in emergency medicine, anesthesia, neurosurgery, orthopedics, burns, plastics, and cardiothoracic surgery, nurses, radiographers, ultrasonographers, reception, helicopter crew, helicopter paramedic, and ambulance control. We scan patients or send them to hospital for CT based on the NICE guidelines, but actually our threshold for that is lower. The G-forces that are involved in some of these impacts are significant. So I would often send somebody for a scan, even if they didn't meet the NICE criteria. And what we're doing is some studies now in Cambridge where we're actually going beyond CT and getting MRIs. In terms of the more trackside approaches, and this applies, as I'm sure you're familiar, to other sports, we tend to use the SCAT5. And what is critical, and perhaps we could talk about that in the discussion, is how we get return to race once a patient's had a concussion and getting them back into sport. As I said, as well as the drivers, we are responsible for medical care of the crowd. When you've got 150,000 people in one place, the odds are during that day there will be at least one serious medical illness. There was about 4 years ago, we were just at the start of the Grand Prix and the patient had a cardiac arrest in the middle of one of these grandstands. So we were having to deal with that at the start of the race, and they said, you just crack on, we get the race going, and then we have our separate medical team comes out from the medical center to deal with that casualty. So the spectators, if they have major injuries, go to the same place as the drivers without with minor injuries, we have a number of first aid posts and a public medical centre. We see all sorts of things. It's a great place to see medicine. Cuts, hypothermic infants, headaches, requests for the morning after pill, myocardial infarction, cardiac arrest, epilepsy, asthma, head injury. And then we had the huge challenge over the last 2 or 3 years of continuing to run this event during the COVID pandemic. And that was a major logistical challenge, but it's something that was possible to deliver with sensible management of the crowd. So I'd just like to acknowledge my colleagues at Silverstone, Ian Roberts, Motorsport UK, the governing body of motorsport in the UK, the FIA. That's me on Twitter. That's my email address. Thank you very much for the invitation to talk to you. I hope I've left, where are we, 1940? Yeah, we've got 20 minutes or so for questions. If you've got any questions about TBI or motorsport medicine or other aspects of sports medicine related to brain injury, I'd be delighted to answer them.
Yep, so if anybody has any questions, you can just unmute and ask, or you can put them in the chat.
Yeah, so that's a great question. So Martin, I may have missed this, but do you have to undergo training to be on the race medical team? And if yes, what sort of training? So what we like on the medical team is somebody as a minimum to be fully registered with the GMC, to have ideally done, or we can help them undertake an ATLS course, and you need to be registered as a doctor by Motorsport UK. But we provide training sessions at the circuit for people who are interested. So we do have days in terms of training in motorsport medicine. But if you've done a job in the emergency department in an NHS hospital, that's a lot of the training, a lot of common sense. So when you're new, we wouldn't put you out on the track by yourself. You'd be there with somebody with somebody else supporting you. The other point is that what I've talked about is very much the Grand Prix in Formula One, but there's motorsport going on most weekends at Silverstone. There's nearer circuits, Snetterton in Norfolk, Brands Hatch not so far away. So if you're interested, there's lots of opportunities to get involved in motorsport medicine beyond the Grand Prix itself. So that's a good question. But just to say that there is training provided, and we'd be happy to assist. So if any of you are interested, then I can link you up with the medical coordinator at Silverstone. So Laura said, thanks so for the extra talk. I read Prof. Watkins' book, and it was clear the emphasis on safety. And as you mentioned, we've seen the hands and halo. What do you anticipate will happen in the future with safety changes and advancements? Okay, so that's a really good question. So I think a lot of the advancements that we're seeing at the moment are beyond the driver and the car, and it's about safe design of circuits. As I've said, what we're doing with the runoffs, trying to move away from gravel, decent sized runoffs, and looking at the barriers. Of course, the other big issue is Formula E. So electric motorsport is becoming increasingly important. I suspect that will move the same way as road cars are in terms of electricity. So that's produced some extra safety challenges in terms of batteries. But on the whole, there have been some really, really good advances. And what's paramount when the FIA look at these accidents, they study very, very carefully the cars when they're involved in the severe accident. And I think what we've learned is to make sure that the cockpit, the safety cell with it, the driver sits, is really strong and impregnable. So if you look at the whole of the rest of the car may be disintegrating. I don't know if you saw at Monaco, Schumacher's car was actually in 2 pieces, yet he walks away from it. So the peripheral parts of the car are often designed to collapse and absorb impact, but as long as you've got that real safety cockpit around the car, that safety cell around the driver, that's paramount. So advice in trying to get into this field. Just funny, I'm becoming president of King's College London SEM. So we'll have to go to both Silverstone and Abu Dhabi. Okay, so we do offer as medical students some positions to observe at Silverstone. I can help connect you with that. I think it's often better, and you'll probably get more out of observing, and not the Grand Prix, but to actually go to some of the other smaller events. The Silverstone Classic's a good one, but And in terms of once you qualify, get yourself on an ATLS course. We do run them at Silverstone once a year. That is one option. If you email me and you're interested, I can certainly put your name forward for that. There are limited spaces. But again, depending on where you live and where you're going to be, there will be a circuit relatively near you. And it has been a struggle. I think previously we did get a lot of juniors. I think with junior rotors, it has been a little bit more difficult getting people. But if you're interested in motorsport, it's actually quite a nice way to spend a weekend. You meet your colleagues, you have good fun, and you're doing good. I'm happy to take questions on the chat, or if you want to shout out, that's fine too. Okay, get into the subspecialty. Do you mean, Alice, do you mean the subspecialty of neurosurgery or in related to motorsport or trauma within neurosurgery? Can you just clarify?
Yeah, I just was wondering. Oh, sorry, I thought I'd unmute myself to speed it up.
Yeah, that's perfect.
I just sort of wondered how you got into motorsport, really.
Okay, so I got into motorsport. I was a houseman at Bart's. This was 1990, long time ago. And the Motorsport UK have to license each motorsport event. So anything from karting, I mean, I've talked about circuit racing, but karting, a lot of motorsport is what we call sprints or hill climbs or rallying. And they actually mandate that doctors, suitably qualified doctors, have to be present in order to the event to get its license. So they were short of a doctor at what was called the Winter Rally in Bournemouth or in the New Forest. So I actually did an event down there as a pre-reg houseman. And now I think it's more difficult. I think you have to be registered properly to do it. And that's how I got into it, and then did a few rallying events. But it's quite interesting that you can be on the glorious sunshine at Silverstone on the start-finish straight at the beginning of the race with the red arrows coming over. And it is a fantastic atmosphere. You're always a little bit on edge because you never know what quite might happen one day. And then you can be in November in the pissing rain in the middle of some forest with a rally car going past. So it does give you a variety of different experiences in life. It's funny when I give these talks, you always get talks about the motor racing and not the TBI, but that's how it is. Anybody got any other questions?
I've got a question, if that's all right.
Yeah.
I was just wondering, with all the safety improvements to just racing cars in general, would you say that most of the injuries that you see nowadays are neurotrauma as compared to things like fractures and physical injuries?
So again, that's a really good question. So most of with the improvements in safety, we're seeing less injury to the body in general from direct trauma. So by that, I mean by direct impact. What we are seeing, and it's becoming more of an issue, is less of the major brain injuries, but we're seeing a number of patients with mild traumatic brain injury and concussions. And for some reason, we're seeing a lot of this in what we call tin tops, so closed cars. So the British Touring Car Championship, these aren't open cockpit racing cars with the halo. These are the conventional, they look like conventional cars. And for some reason, we are seeing quite a lot of concussion in these patients. There is even a theory that we're perhaps seeing more since the HANS device came in. But a lot of this is not due to direct impact to the head itself. It's when the car is hit, when the car is spinning and the head and the helmet are rotating on the torso. And this rotational injury, I think, is provoking a number of mild TBIs, concussions. And we are seeing quite a lot of that. There's a race called Ginetta Juniors. So this is teenagers racing, and they get themselves in all sorts of incidents, but a number of them are getting concussion, and these are the sorts of concussions that we also see in rugby. They're similar in terms of the presenting symptoms. So Rachin, I've heard that many bobsleigh athletes suffer long-term symptoms of recurrent concussions or microconcussions because of the constant rattling of the sled. Yeah, why don't we hear much about ex-F1 drivers suffering from the same problems? I think that's partly related to dose and partly related to the comparison of the forces that they're exposed to bobsled athletes. So although they are getting G forces applied to them, they're generally smooth unless you're going over the rumble strips or slightly off the edge of the track. On the whole, there is not that jolting to the head. It's more diffuse type G forces, and fundamentally, motor racing drivers are not spending huge hours, many hours of their life actually racing. If you look at the dose of that when they're actually racing, it's not like it's there. They're not doing it 8-10 hours a day for every day. It is slightly more restricted than that. But again, it's a really good point. Please shout out if you've got any more questions.
I had a question, if that's okay.
Yeah.
A bit more on the traumatic brain injury side.
Yeah. Okay.
So I'm sorry if we already covered this, because I said to Clement earlier my internet was a bit choppy.
Don't worry.
Obviously, neck strength training is used as like a preventative measure for concussions. And Formula One drivers have to have strong necks anyway for the G forces.
Sure.
I was wondering at the top level if there's actually much difference in neck strength between the athletes, and if it's like a proportional increase, or if it's more of a once you're strong to a certain level, it kind of plateaus off in usefulness.
I see what you mean. Whether there's a point at which going above and beyond that, becomes more. Yeah, I guess there's a point at which you need to achieve, and in terms of the risk and the forces that are applied, I'm talking out with an accident, and whether you go beyond that is probably not particularly relevant for conventional racing. But I guess if you're going to be involved in some sort of an impact, then greater neck muscle bulk and protection would be better. I mean, I've treated a number of these guys at this level, and they are exceptional athletes. I mean, I've treated rugby players, football players, but the F1 drivers are, that their level of physical fitness is unbelievable. Their level of intellect and cognition is also amazing. We've done neuropsychological testing, some reaction time testing on F1 drivers, and they are extreme human beings. I mean, I've seen the data from one of these drivers compared to the general population. It is extraordinary, to the point that you could wonder whether you could actually use some of these tests to select good drivers in the first place. That they are very smart physically, but also intellectually and cognitively exceptional.
Yeah. If there aren't any more questions, I think this will conclude our talk. Thank Professor Hutchinson for speaking. And yeah, hope everyone has a nice day.
Yeah, it's a pleasure. And as I said, if anybody wants to get involved as an observer, I can certainly point you in the direction if you're interested in getting involved in it.
I think there is one more question.
Yeah, well, that's a good question to end on, Alice, because I think that's a difficult question to answer. Cause or effect. I think to get into that sport and work your way up to the F1, you've got to be mentally and physically exceptional to actually get there, in terms of physical fitness, but also your ability to manage not only the driving and the car, but the whole concept of being an F1 driver, in the way you deal with the media, the pressures on you, the teams. There's an awful lot of pressure. I'm sure many of you have seen Drive to Survive, and there's a whole lot of stuff going on actually outside the car in this sport, which some people, it's incredible, the whole spectacle of the thing. That's a good question to end on.
All right. Thank you, everybody, for coming.
All right, pleasure. It's lovely to see everybody, and it's strange, you know, that the world of and the time of Zoom. In some ways, it's not as good, but I'm sure there's talks that are happening because of Zoom that wouldn't have happened before COVID. But I'd be delighted to talk to you again. And if you're looking for other speakers, I'm sure we can help. You know, thanks for the invitation, and wish you all a lovely evening.
Thank you
Very much.
Bye-bye.
Thank you.
Bye.